As you have heard, I'm an interventional cardiologist, and it's very important also to know a lot of things about heart failure. On one hand, we are doing a very good job with our stents and our techniques, so preventing dying from myocardial infarction. However, indirectly, thereby we are producing survivors with reduced ejection fraction, so we interventional cardiologists are also guilty by producing patients with heart failure. And therefore, it's so extremely important to know what's going on here. You see here worldwide, more than 26 million patients have heart failure. The prevalence is high, is rising and rising, and the reasons behind the good job of interventional cardiologists is, of course, aging and an increase of risk factors, especially also true for your country, thinking about diabetes mellitus. Fighting against heart failure means that we do not have stents itself. We have specific medications, and they are summarized here on this slide, and especially those who interfere with the neurohumoral activation, like ACE inhibitors, together with beta blockers and aldosterone antagonists, are those drugs which help us. And you can see, although that we have these drugs, mortality is still high. You see that here about 50% of the patients are not anymore with us after the first diagnosis of heart failure. So that means we still have to do something. And in the last years, it came up in new strategies. This is here just a slide from the European Society of Cardiology, how to fight against heart failure. When we see that patients still suffer despite ACE inhibitor, aldosterone antagonists, and beta blockers, we get 3 new tasks. One of them is to prove what's going on with the heart rate. Is the speed higher than 70 beats per minute? Despite beta blockade, we have to add ivabradine. This is at least the belief in Europe. And the target heart rate is about 60 minutes per minute in patients with reduced ejection fraction. The other task we got is think about the QS duration. This is larger than 150 milliseconds. Then we have to give a CRT system. And now it comes something what is extremely surprising, as it came up before, is that guidelines recommend to take the ACE inhibitor away in a patient where you have signs of the progression of the disease. And that is really something what sounds as a paradigm shift, because usually I would have told you when the patient's disease is progressing and progressing, add probably more ACE inhibitor. But here the guidelines say take the ACE inhibitor away and give therefore another drug which we call ARNI. And the reason for this is, according to the paradigm trial, where the first ARNI, sucralfate valsartan, had been investigated in about 8,000 patients with reduced ejection fraction. They had been treated optimal on the base of an ACE inhibitor or on sucralfate valsartan. We got an additional risk of about 20%. However, calculating relative risk, I think this is not really something what you can grab. A patient who knows that he has a disease which kills him with a 50% chance in the next 5 years, you want to know how many years I could live longer, and this is summarized on the next slide, and you can see here, let's have a shift here to the left side, that a 55 years old patient has a chance after a simple shift from an ACE inhibitor like enalapril to an ARNI, that he can live about 2 years longer. And also with respect to the clinical progression, not only the question, can you live longer, but also the question how often the patient has to be retreated in the hospital is significantly reduced. So these are the data which have changed worldwide all heart failure guidelines. And this is here just an example from the American guidelines, and they have two different clinical scenarios characterized. The first one is that they say, if you have a naive heart failure patient in front of you, it is allowed to start with an ACE inhibitor, with an AT1 receptor antagonist, an ARB, or an ARNI. Or they describe the other scenario. The patient had been already pre-treated, for instance, with an ACE inhibitor, but we have signs of the progression of the disease. Then they recommend both clinical scenarios, recommended as a class 1 scenario, as a replacement scenario. So these are the clinical data and the guidelines. And the problem of a study or guidelines is that very often our problems in the clinic are not really covered. Very often our patients have more problems in addition, they are older, they have more comorbidities and never had been investigated. So the question is how to deal with these patients with respect to real life scenarios. And as this drug came in my hand at my clinic, I wanted to have it, of course, also for my patients, and I introduced my young doctors just with 3-4 different informations. First of all, I told them that it is possible that when the history of angioedema due to an ACE inhibitor is positive, the patient is not eligible for an ANI. And that has the consequence that when the patient has been pre-treated with an ACE inhibitor, you need a 36 hours washing out period, and then you can titrate. If the patient has been already pre-treated with an ARB, you can switch immediately. And the other thing I told them is, it is possible that you affect blood pressure, and therefore sometimes, especially when the blood pressure is lower than 100 millimeter of mercury, first you have to prepare the patient for an ANI. So that is all what I told them, and so it means it is relatively easy for us to use the drug as heart failure specialist. But still, I have now 4 cases prepared, which I would like to discuss with you and to show what kind of thinkings and probably troubleshootings are necessary to help our patients. So this is a 55-year-old lady with an ischemic cardiomyopathy. Ejection fraction is fine. NYHA class 2. So she was not a patient just left the intensive care unit. She was a patient in my out-clinic situation, and she felt fine. She had no signs of congestion, and she was on a very good treatment, I think. High-dose ramipril as an ACE inhibitor, high-dose metoprolol as a beta blocker, long-acting loop diuretics. And I asked her, how do you feel? She said, fine, I'm not complaining. I asked her, how many steps are you walking? Oh, doctor, I'm not really walking steps. I have an elevator. So you see, the lady found already some tips and tricks how she could survive with her disease. And the question here is this a patient where we should think about to switch from an ACE inhibitor to an ARNI? Officially, she looks stable. She's not complaining, she's on a good treatment. However, she's good treated, and she's also very good treated with a diuretic. Diuretics are cosmetics. With diuretics, I'm able to stabilize patients very easy. So I think I need objective parameters, whether not only the patient, but whether also the heart is happy. You can do that with different things. You can do 6-minute walking test. I have investigated natriuretic peptide levels. So NT-proBNP was very high. So the progression of the winner of these patients in the trial, and therefore I had decided to switch the patient to ARNI under these conditions. Relatively easy. I just have taken away ramipril under these conditions, and what we can see under these conditions is that the BNP levels just were wonderful, reduced nearly up to a half, and also the patient itself, yes, she was NYHA class 2, but she told me, yes, doctor, I can realize that something happened, and that is also what we know from the patients when we speak with them. So summarizing this case, when we speak about change from an ACE inhibitor to an ARNI, then we do not think every time about a NYHA class 3-4 patient and no option patient, clearly before decompensating. We think about NYHA class 2 patient mainly, especially in those where we have additional signs for the progression of the disease. So let's come to this case. I think this is an easy case. NYHA class 3, patient is complaining. He has a good treatment, and with high dose of ramipril, high dose thiazides, metoprolol, and spironolactone. And I think it's clear we want to switch here because the patient itself shows you already clinically that something does not go in the right direction. That we have done, we just have taken ramipril high dose away, gave Entresto high dose twice 200 milligram, and suddenly we had this problem. Systolic blood pressure was 90. What to do? Panic? No, I think there's no reason for panic. I think we have principally 3 strategies. First of all, go to the patient and ask, how do you feel? It's an asymptomatic hypotension. We should accept that. Sometimes doctors are coming and say, yeah, that is clear, because valsartan, sucralfate had been used twice 200 milligrams. So the dose is too high. So just don't titrate. I do not believe this is the best, because I strongly believe that in the trial, the winner was the neprilysin inhibition. And only when you have used twice 200 milligram, then you have a great chance that the neprilysin enzyme activity is inhibited up to 95%. So I would like to keep these doses, but I would like to see whether probably the other drugs, the co-medications, when I reduce these, I can produce some place for an ARNI, the drug, why a patient can live up to 2 years longer. So coming back to the mode of action, how an ARNI is working, ARNI is inhibiting these enzyme neprilysin, which is controlling the degradation of natriuretic peptides, and natriuretic peptides have a natriuretic diuretic effect. So when you block neprilysin, you induce thereby also diuresis. And therefore, it is meaningful, and that happened also in the paradigm trial summarized in this slide, that doctors, when hypotension occurred, thought about to reduce diuretic co-medication. I never would go so far to say take it completely away, but I would say adapt the dose, produce some place for an ARNI, because this is the life-prolonging drug under these conditions. And therefore, we have done the following. I have just reduced thiazides, and I have used a long-acting, low-dose diuretic. I also have reduced spironolactone, and as you have seen, the patient had also some drugs on board which are not really necessary, some nitrates, called in my country Isokit, and I just have taken it away and just gave him some spray. So under these conditions, I think I could keep high-dose and valsartan sucralfate. Blood pressure went up, and I think this is the better treatment, and the patient was also more happy with respect to the NYHA status. The key message here is, in the clinical routine, it can be possible to deal with the co-medication, in these cases with the diuretics, to produce place for a high-dose drug, which is really life-prolonging. What about this patient? The patient has an ejection fraction of 25, NYHA class 2 to 3. The patient is really sick, systolic blood pressure lower than 100, and my colleagues were only able to give low-dose candesartan as an ARB, 4 milligram. I think that means nothing. It is more or less a pediatric or psychiatric dose, together with a little bit beta blocker and a little bit spironolactone. I think this patient is really sick. I have not measured here natriuretic peptides, but I'm pretty sure we have to do something that the patient is here improving. So, from my feeling, I would like to see sucralfate valsartan in this patient, but on the other hand, we have this blood pressure issue. What to do? I think we should switch, because we have data showing that even low dose of an ARNI is better than a low dose of an ACE inhibitor, as you can see here. And even the mid doses of an ACE inhibitor was not as good as a mid dose of an ARNI. So I was pretty sure that I was never able to give these patients I have described before twice 200 milligram. But these data here indicate that even twice 50 milligram are better than 4 milligram of candesartan. So if I summarize this here together, I would say, when we have an ARNI on board, we have to control in the next 7 to 10 days blood pressure, potassium, and kidney function. If this is fine, everybody is happy. If you have hypotension, and it is not a symptomatic hypotension, everything is fine. It is a symptomatic hypotension, then prove the co-medications. And only when, even after proving the patient still have symptoms, then reduce the dose and adapt so that the patient feels happy. So that is what we have done under this condition. It was clear for me that sucralfate valsartan, as he said, 696 was a prolonged name before, I could use only twice 50 milligram. And I have done a good thing for the patient. E to E prime followed, blood pressure stayed stable, and I'm pretty sure that the patient has now the best treatment ever as possible. So that I would say here is my credo, even a low dose of sucralfate valsartan is a treatment target what we should offer our patient. My last scenario is renal failure. Renal failure and heart failure, of course, belongs together, and this patient here is suffering from heart failure, NYHA class 3, has a GFR of about 30. He had been pre-treated, in this case with an ACE inhibitor, lisinopril, and very often the doctors are asking me, what does that mean if I switch? Is this good or is this bad for the kidney? And here we have fantastic data. We can see here on this cartoon that also the progression of kidney failure is slower due to the drug. There are a lot of mode of action which can explain that. One of them is that we say when heart function is improved, also kidney function is improved. And for me in the clinic, it's extremely important to see that the potassium values stayed more stable under these conditions. And this has consequences for the co-treatment with the mineralocorticoid receptor antagonist. And you can see that here, if you combined mineralocorticoid receptor antagonist with an ACE inhibitor, the risk of very high potassium is very, very high, so that you in the end produce a non-responder for mineralocorticoid receptor antagonist if you compare that with sucralfate valsartan under these conditions. So for me it means, especially when you have a patient with reduced kidney function, consequence of heart failure, this could be an indicator that the patient will have a further benefit of the new drug. I never would go so far to say do it in patients with dialysis, and probably in patients where GFR is really low, you should do it in caution, but principally I would go for the new drug. So I come to the end and I would like to summarize. You have different clinical scenario. This is more or less the first American way where in all classes of heart failure, when ejection fraction is reduced, even in new heart class 2, you can start with an ACE inhibitor, an ARB, or an ARNI. When the patient had been already pre-treated, very often the clinical situation is difficult to decide when is the best way to switch, especially when the patient is new heart class 2. The patient looks relatively able and safely. Then I think we have to search in the clinic for so-called red flags. This can be clinical markers, serum biomarkers, hemodynamic changes. So when GFR, kidney dysfunction occurs, BNP is rising, or the patient has been already re-hospitalized, so it's a really clear sign that the ACE inhibitor is not anymore good enough, I think we have to switch under these conditions, so the patient needs the advanced therapy, probably in addition with ivabradine, with CRT, but in most cases the patient needs an ARNI that he has the best outcome chances. So I summarize, heart failure prevalence is increasing through the world. We have a triple therapy which is good, but for the most not good enough. Hypotension is manageable. This is not a contraindication. It belongs to the disease, and we as heart failure specialists are able to do so even in new heart class 2 patient, because mild symptoms does not mean mild disease. Thank you very much for your attention.